majority of our individuals with metastatic lung cancer, particularly squamous cell, have symptoms, 2/3 to 3/4. This person is highly symptomatic. From the standpoint of squamous histology, we know that a weekly NAB-PAC with carbo is superior to our more conventional Q3-week solvent-based PAC carbo regimen with response rates of over 40% compared to about 25-26% for the control arm. So simply from a symptom standpoint, NAB-PAC, I think, offers an advantage over conventional solvent-based paclitaxel. From the standpoint of this individual's age, she's 70, so she just makes the cutoff. We have nested post-hoc subset data that strongly suggests a survival advantage, 9.5 month advantage for NAB-PAC and carbo compared to solvent-based paclitaxel and carboplatin. And this is being looked at prospectively in additional phase 2 and phase 3 trials. Here it may be a bit more debatable whether to actually order mutation testing. This individual is a past smoker. He's got squamous cell histology. The likelihood of having an actionable EGFR mutation or ALK translocation or ROS1 translocation is probably under 5%, more likely the order of 1 to 2%. She's highly symptomatic. We really can't wait for those test results. So while I would have ordered these tests, I highly doubt whether I would have waited for those results to come in. And we can even debate whether it makes sense from a cost-efficacy standpoint to routinely obtain mutation testing in individuals with a smoking history and squamous histology. What do we do if and when the patient manifests disease progression on the current chemo regimen? Well, we do have therapeutic options. Up until 2015, our standard approach was docetaxel or docetaxel combined with ramucirumab. The two-drug combination angiogenesis inhibitor with docetaxel had shown a survival advantage compared to docetaxel alone. And this included both non-squamous as well as squamous histology. So in contrast to bevacizumab frontline, where squamous cell was a contraindication, ramucirumab was FDA approved specifically for individuals of this sort, squamous cell with disease progression on a platinum-based regimen. More recently, there have been not one, not two, but 3 separate prospective phase 3 trials showing a survival advantage for checkpoint blockade over docetaxel, which is now our former standard. The first trial looked at nivolumab specifically in squamous histology compared to standard full dose docetaxel at 75 per meter squared. Q2-week nivolumab was clearly superior, much higher response rate, nearly double, close to 20% overall response rate, progression-free survival that was 50% better, and a 3.5-month improvement in median overall survival with a near doubling of survival at 18 months and 2 years. Unprecedented data with incredibly promising hazard ratios and p-values, and literally overnight, nivolumab became our standard regimen in the second-line setting in individuals with advanced squamous cell whose disease had progressed on standard chemotherapy. Nivolumab is not the only agent that's available for use in this setting. Keynote 010 was a phase 3 trial comparing 2 different doses of pembrolizumab in individuals with minimum PD-L1 expression levels of 1% or higher versus standard docetaxel, and both pembro doses resulted in statistically significant, and I'd argue clinically meaningful improvements in overall survival. And now we've seen data for atezolizumab, PD-L1 inhibitor, as opposed to pembro and nivo, which are both PD-1 inhibitors. And here too, compared to docetaxel in the OAK trial, randomized phase 3 trial, once more we see a survival advantage that seems to be independent of either histology or PD-L1 level. So it's not a matter of whether to use checkpoint blockade in this setting, it's a matter of which checkpoint inhibitor to institute. And in this regard, there's tremendous debate.